question, what causes it? Well, here's what we know so far. I'm going to take you inside the blood vessel here. And you can see we have those red blood cells. We have something called von Willebrand factor, and we have the platelets. And what happens here is we have ADAMTS13, which is what I describe as the scissors of the cell. So what ADAMTS13 is supposed to do is actually clip this von Willebrand factor, just like that. So it's just kind of making these von Willebrand factor, we call them multimers, into smaller pieces so things can nicely flow through the blood vessel. Well, when you have a deficiency of your scissors, when you have ADAMTS13 deficiency, those von Willebrand molecules aren't cut apart like they're supposed to be, and then the platelets basically get caught up in them. And then when things try to flow nicely through the blood vessels, you get this shearing effect where the red blood cells kind of get broken apart as they go through. And so that's what causes this thrombotic thrombocytopenic purpura, is that you get these low platelets that are literally just being caught up in this von Willebrand factor. You get these weird appearing red cells, which are schistocytes, and that's what causes the anemia. And then furthermore, when you have so many platelets kind of getting caught up there, you don't get good blood flow. And when you don't get good blood flow, you can get things like stroke or kidney injury. And that blockage of blood flow is exactly what's causing that. So how we diagnose it is really looking for those things, right? So we're looking for, when a patient comes in, first it's recognition, really getting the word out about what these symptoms can look like. And then we look at platelet counts and red blood cells. And then one of the advances in TTP diagnosis among clinicians has been using something we call the plasmic score, which was a study that was done to try to make it easier to recognize TTP, because sometimes the lab testing isn't back right away. And so they've done a lot of work trying to kind of validate this score to help clinicians who may not have the ADAMTS13 test back right away to determine who needs treatment right away. And so that's been a major kind of simple advance, is just coming up with a score to more quickly recognize cases. And then the other kind of key to diagnosis is that lab test. Is actually we can measure the amount of scissors, or the amount of ADAMTS13 in the blood. And an ADAMTS13 level of less than 10% is really diagnostic of this diagnosis. And so why would ADAMTS13 be low? Like, why does this happen? Well, we don't know exactly what triggers it, but we do know that it's clear that there's an antibody. So, you're supposed to make antibodies to things like viruses, or when you get a vaccine, you're supposed to make an antibody. But for some reason, patients with TTP they start to recognize their ADAMTS13 as not self and start to either clear it or inhibit its function. Other patients, it's more rare, but you can have an inherited mutation or a gene that causes low ADAMTS13. And so we really have two types of TTP. The far more common in adults we call immune or acquired TTP, meaning you're not born with it, but you have an antibody. And then you have hereditary TTP, or we also call it congenital TTP, is where that's really an inherited genetic mutation that you have. So we heard a little bit about how we now treat TTP, but to give you a sense of where we are and where we're going, there have been, the ISTH is an international society of thrombosis and hemostasis, and they've put together a guideline panel of how to treat TTP. And we know still a very key part of therapy is what we call therapeutic plasma exchange, or PLEX. So this is something that not many people outside of those who know family members or personally experienced TTP will know about. But if you think about it, the goal is really to give patients back their scissors, to give them the ability to cut back up that von Willebrand factor again, and then to clear the antibody. So for most cases, it's an antibody-mediated process, and you want to get rid of it. So what we do with therapeutic plasma exchange is we take the patient And unfortunately, this involves putting in a large catheter, which is a very big deal initially. Once it's in, we can take the patient's plasma, put it through a filter, and then give them fresh frozen plasma back. And what this is doing is actually removing the antibody and giving them back their scissors, their ADAM-TS13. And this, it can take a while, so as we heard, you can have to have multiple treatments. Some people are very refractory TTP and need to stay in the hospital for weeks with this. And then the other approach to therapy is we have steroids and rituximab. And what those therapies are really going after is this antibody to ADAM-TS13. Is trying to get that antibody to go away. And so rituximab was originally just used for patients who are very refractory to treatment, but now we've actually moved it up. It's been shown to be effective, to be given kind of earlier in treatment. And it's been shown to be able to decrease the time on plasma exchange and potentially reduce the exacerbation rate. And that means the chance of getting TTP again. We also heard from Sanofi about the only FDA-approved therapy, which is cabazitaxel. And I think of this medication as really blocking platelet binding to von Willebrand factor. So this has been a major advance for patients because it works very quickly, and it is continued after a patient stops the plasma exchange to kind of prevent those early exacerbations, or as we were describing that, I stop the therapeutic plasma exchange and my platelet count falls again. And so that was a major advance for patients with TTP. And then as far as follow-up for patients, so unfortunately, as we again heard from our survivor, is that I think people used to think of TTP as like a one-and-done thing. It's not. Patients can unfortunately have relapses. Some people will just have one episode, but there definitely is a relapse risk. And so we now kind of consider preemptive treatment for patients who don't yet have a TTP relapse, but have low ADAM-TS13 levels. We also know that even outside of just of TTP episodes, patients who have had a prior episode also have long-term complications, such as increased risk of preeclampsia if they go on to become pregnant, strokes, hypertension, and because this is such a traumatic event that they've never heard of this diagnosis often before when they come into the hospital, there's a high incidence of post-traumatic stress and depression. And for patients with hereditary TTP, so remember this is going to be a rare diagnosis in adults, estimated less than 5%, but there's fortunately genetic testing available for those patients. And they are treated in a similar way to patients with immune TTP, except that we don't have to get rid of the antibody, so we can just use plasma infusion. So plasma infusion isn't enough for someone with immune TTP, but it is for congenital TTP. So this is showing we would give plasma infusions for that, and then where are we going? So our last slide here, like what's next for TTP? Well, we're still trying to figure out for immune causes, what's the best immunosuppressive regimen? We know that people don't always have the same responses to prednisone and rituximab. There's been a development of a question of the role of recombinant ADAM-TS13 or man-made ADAM-TS13 because that's what's lacking in some cases. And then there have been some case reports out there, though cabazitaxel right now is only approved with plasma exchange. Could it be done without plasma exchange or without the catheter is an area of potential interest. And so our take-home points is that TTP results really from this lack of scissors or ADAM-TS13 deficiency, which is in the most case an autoimmune or immune cause, but it can be congenital. That patients and families, we heard again all about the signs and symptoms of TTP, like abdominal pain, fatigue, confusion, strokes, because you need to get treatment really right away because it is life-threatening. And there's lots of exciting work to be done in TTP, and we hope for more advances to come. And a really big thank you for all of you for listening and taking the science lesson. We'll get back